Genital ulcers is going to compare 4 different ulcerative diseases that are very often tested against one another. And what I want you to be able to do is identify which ulcer disease it is, even before you get a diagnostic step, but know which diagnostic step and which treatment to use for each of the individual diseases. So how are you going to do that? Well, it starts by identifying a genital ulcer. And the very first thing you're going to do is use the number of ulcers, whether or not there is pain or not, and then the presence of lymphadenopathy with or without pain. And with these 3 pieces of information, you can pretty much get the diagnosis right. Knowing these 3 pieces of information are going to separate your differential into one of 4 diseases. That is going to be syphilis, lymphogranuloma venereum, chancroid, and herpes. Let's explore each of these in detail. Syphilis being the one you have to know the most about, so that's the one we're going to start with. Syphilis is caused by infection of Treponema pallidum. And depending on the state of infection, the symptoms will vary. And so you have to be able to identify primary, secondary, and tertiary syphilis. Because we're talking about this in the ulcer lecture, it's not a surprise that syphilis might cause an ulcer. The ulcer of syphilis is going to be singular at the site of inoculation, painless, with lymphadenopathy, but it's non-tender. Patients may not even notice primary syphilis because it doesn't hurt. The ulcer can be disconcerting, but the lesion itself doesn't bother the patient. They are infectious. Don't touch it. But if the person goes on long enough and doesn't receive any therapy, they'll turn into secondary syphilis. And secondary syphilis is going to present with fever and a rash. That rash is going to appear targetoid and will involve the palms and soles. For whatever reason, most rashes tend to spare palms and soles. And so the only targetoid lesion you should think of that involves the palms and soles, other than syphilis, is erythema multiforme. More on that in the derm lecture. This is secondary syphilis. And over years to decades, if you don't treat secondary syphilis, well, then it burrows its way into other major organs. And the big one we care about the most is neurosyphilis. Any neurosymptom can be neurosyphilis, but the one you should really pay attention for is tabes dorsalis, the loss of the DCMLS. Tabes dorsalis is going to present as flip-flopping on the floor because the patient can't feel the ground. They've lost proprioception, particularly the old rake. The old guy who used to have a lot of unprotected sex who now can't find his feet in space, it's got tabes dorsalis. And the other thing you can look for is the Argyll-Robertson pupil. That is, under accommodation, you shine the light in the right eye, accommodation, the left eye constricts. You shine the light in the left eye and it doesn't do anything. These are signs of tertiary syphilis. To make the diagnosis of each of these conditions, I want you to break them down into primary, secondary, and tertiary syphilis. In primary syphilis, you can see the chancre, the painless ulcer. But there hasn't been enough time for the body to develop antibodies. So on the test, what you want to pick is dark field microscopy, knowing that most people don't even know what a dark field microscope looks like unless you work in an infectious disease clinic. The answer on the test is dark field microscopy. Why? You have to see the Treponema pallidum and you won't be able to get positive antibodies. For secondary syphilis, what you want to use is serologic testing. You use a non-treponema test, like an RPR, which is better than the VDRL. And if positive, you confirm with treponema antibodies. You do a non-treponema test, which has good sensitivity, but could have false positives. And if positive, you confirm it with the treponema test, which confirms the diagnosis. That's enough to treat. Tertiary syphilis is neurosyphilis, and so you have to get into the CSF. You do that with an LP, and on the LP, you run an RPR on the CSF. And if it's positive, you run the treponema test on the CSF. Treat if positive. So how do you treat? Well, the treatment is going to be penicillin. If you have primary syphilis, it is penicillin. You give it one time, IM, and you call it a day. If it's secondary syphilis, you give penicillin times 1, IM. If it's tertiary syphilis, you still give penicillin, but now you need to give it IV, Q4 hours, for 10 to 14 days. You notice I left a spot here. I did that on purpose. I've lied to you. It's more than just primary, secondary, and tertiary syphilis. You also have to worry about early latent and late latent. Early latent and late latent. What the hell is latent syphilis? Primary, secondary, and tertiary have symptoms, and then you get the test to confirm the diagnosis. Latent syphilis is going to be positive serology without symptoms. Now, if you know you were exposed within 1 year, you have early latent syphilis, penicillin times 1 IM. If you don't know when you were infected, or it's been more than a year, you have a late latent syphilis, and you have to give penicillin. But you give it IM weekly for 3 weeks. I did it this way on purpose. Primary, secondary, and early latent, one time penicillin in the arm, call it a day. Late latent penicillin 3 times weekly. Tertiary or neurosyphilis, Q4 hours for 10 to 14 days. And I also want to mention the RPR because this is important. The RPR is generally presented as a number, colon, another number. This is not a fraction. The bigger the number after the colon, the more positive the RPR. It's the number of dilutions in which the RPR test is still positive. And what you want to see after you treat syphilis, you should follow up with a repeat RPR, repeat serologic testing. You want to see the number decrease. And the RPR is probably always going to be positive, but so long as the number after the colon is small, you don't need to treat again. And anybody exposed to syphilis has been exposed to HIV, they need an HIV test. A lot you had to know about syphilis, really annoying. The other ones are not nearly as complicated, so dedicate most of your studying in this lesson to syphilis. Lymphogranuloma venereum is caused by C. trachomatis. Very rare in the United States, therefore it occurs all the time on the test. Like syphilis, the ulcer itself is painless and singular. But what you'll see is positive lymph nodes that are tender, and that tenderness is going to separate it from syphilis, and these may get suppurative and drain. If they do, you can run a nucleic acid amplification test to confirm the diagnosis, and the treatment is with doxy. Look for the lymph nodes that are draining pus. In the immunocompromised patient, that's probably LGV. If you compare these two now to chancroid, which is caused by Haemophilus ducreyi, you do cry with Ducreyi, the patient is going to have a painful singular ulcer that has positive lymph nodes that are tender. In this case, it's the singular ulcer that's painful that separates it from the chancre of primary syphilis. Thus, chancroid, it looks like syphilis, but it hurts. The diagnosis can be confirmed by a gram stain in culture, but generally you only consider this after everything else has been ruled out. The treatment is going to be with antibiotics. You can pick azithromycin or Cipro. And herpes is the most common cause of genital ulcers in the United States. And it is caused either by HSV1 or HSV2. You do not have to memorize the difference between 1 and 2. Just know that certain ones are more prevalent, have a higher recurrence rate, and a higher transmission rate. That whole thing about 1 being below the waist, 2 being above the waist is garbage. People have oral sex, anal sex, vaginal sex. It doesn't matter where it is, but it does matter which one you've got. And as we'll see during the diagnostic step, you'll be able to figure that out. But when you're infected the first time, the herpes virus hides in the dorsal root ganglion. And herpes is the gift that keeps on giving. Once you have it, you never get rid of it. So when the patient begins to experience the prodrome, and that's the thing that separates it from the rest, there will be a painful, burning prodrome that then leads to painful ulcers. But it's probably not an ulcer. It's going to be painful vesicles on an erythematous base. But if there's enough of these vesicles close enough together and they unroof, they can coalesce to form what looks like an ulcer. So if you think this person has herpes because they had the painful prodrome and there's a bunch of vesicles next to the ulcer, you're going to want to diagnose it definitively. It used to be the Zank prep. You look for the perinuclear halos and nuclear molding and blah, 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 blah. Microbiology, step 1, you do not do a Zank prep. Not sensitive or specific enough. Instead, what you want to do is confirm the diagnosis either with a viral culture, which is expensive and silly, so you won't do that, or a PCR. And the PCR is going to tell you, is it HSV1 or HSV2? The treatment is going to be with acyclovir or valacyclovir. Now, I want you to hear, but not memorize, that if someone has an outbreak, you treat them with a certain dose and frequency to reduce the duration of that outbreak. If someone has recurrence, you treat them with a different dose and frequency to treat the recurrent infection. If they have more than 6 infections in a year, you can give them suppressive therapy, which has yet another dose and frequency. What I want you to remember for the test and for being an M3 is acyclovir and valacyclovir are what you have to know to treat herpes. Let's blow through this one more time. In terms of the ulcer, if you see a painless singular ulcer with non-tender lymphadenopathy, that's syphilis. If you see a painless ulcer, but it's got tender, pussy lymph nodes, that's LGV. If you see a painful singular ulcer, that's probably Haemophilus, rule out everything else, and then treat with antibiotics. And if you see a painful prodrome, vesicles on an erythematous base that coalesce to form an ulcer, confirm the diagnosis with PCR, that's herpes, treat with acyclovir or valacyclovir. That is genital ulcers.